Hello, in this presentation at the International Vitamin D Conference 2021 in Abu Dhabi, I am going to discuss about the pros and cons of vitamin D and how to avoid some of these common errors made by the most recent published large clinical studies. So that way the clinical trials can be done with the meaningful end results. So vitamin D is an essential for survival in addition to oxygen, water and food. Next comes the vitamin D for survival, procreation and keeping good health. We expect that the major proportion of our vitamin D to be obtained through the sunlight via ultraviolet rays, but in practice it doesn't happen now because of the changes in lifestyles. The commonest cause of vitamin D deficiency is a lack of sun exposure or sun avoidance behavior. The only way to identify the vitamin D status in a person is by measuring serum 25-hydroxy vitamin D levels. The elderly and those who are housebound or institutional bound like prisoners, so as those who are avoiding sun, obese, metabolic syndrome, gastrointestinal disorders, and those with a dark skin color with preventing UV rays reaching the skin cells, and living in higher altitude, so as vegetarian and vegans, and those who taking types of medication that increase the catabolism of vitamin D, and those who do not take any supplements and living in higher latitudes or taking fortified milk has the highest incidence of vitamin D deficiency. These are the slides, but I'm going to show discuss about the importance of 25-hydroxyvitamin D and differentiate it from the circulating 1,25-dihydroxyvitamin D, which is Calcitriol, related to the immune system, what I call the target tissues. This includes all the epithelial cells, the CNS, and especially the immune system. So, in the renal production of 1,25-dihydroxycalcitol is very important for musculoskeletal function, whereas a target tissue 1,25-dihydroxyvitamin D is a critical factor for autocrine and paracrine signaling of vitamin D. So this is one slide to illustrate the importance of what I just said on circulating 25-hydroxyvitamin D. Here now I call it as a Calcifediol. Now it's diffused into the target tissue cells when the concentration approaches the optimum for the particular cell type, as I discussed in the previous keynote speech. For example, in the pulmonary, gut, and endothelial and all other epithelial cells, so as immune cells, it diffuses into the cells through the circulation when it's reached above 40 and going to be optimum level above 50 nanograms per ml concentration. It enhances the expression of vitamin D regulated genes, and it also encompasses both the innate and adaptive immune functions. So, for example, in the system we have the defensin and cathelicidin, also called L37, some very potent antimicrobial peptides. So, as it also reduces the double-stranded RNA-induced expression of some of these potent inflammatory agents such as IL-8. So, combination of these reduce the risk of viral transmission and indeed infection. So there are multiple extraskeletal beneficial effects of having higher levels of serum 25-hydroxy vitamin D, which again I illustrated in the keynote speech. It reduces certain types of cancer, type 2 diabetes, and indeed the metabolic syndrome. It also reduces the risk of acute respiratory tract infection, including COVID-19. It certainly reduced the adverse effects during the pregnancy and improved birth outcomes, and including the functioning of the infant itself. And finally, it reduced the premature deaths. So, higher the serum 25-hydroxyvitamin D within that range of 30 to 80 nanograms per ml, better the outcomes, especially from current COVID pandemic. There are a lot of beneficial of conducting the longitudinal studies, such as longitudinal aging study of Amsterdam, and these studies have reported the many strong positive association of serum 25-hydroxyvitamin D with cardiovascular diseases, diabetes, respiratory infections, cancer, autoimmune disease, and including the central nervous system disorders like depression and memory, etc. So let's look at what we gather from these larger observation studies, and also look at the same time the poorly conducted RCT, how it can confuse the situation. Firstly, the basic principles. The focusing only on hierarchy like RCTs or systematic review, and these kind of studies may not necessarily be the optimum way to look at research data. Firstly, we need to look at the internal validity. Was the study well designed? Is there any inherent bias? And was the study conducted as originally set up? Consistency. Was there a volume of evidence and direction of the effect is consistent, or is it all over the place? The magnitude of these effects, what we call effect size, expressed as the absolute changes observed, not relative effect, as almost always the pharmaceutical companies with their propaganda. External validity. Does this effect applicable to the general population, or at least to the particular settings of the study or subgroups? The problem is that recently conducted large vitamin D studies, which we'll address in a minute, had a significant study design errors, although they could have easily avoided this. Therefore, some of the interpretation of these studies are not possible. Here are the three commonest study design errors all these studies had. Firstly, the enrolling the subject with a normal or near normal baseline serum 25-hydroxy concentration. In other words, they have recruited the subject already having vitamin D sufficiency, so no more further clinical benefits is expected. Then they allowed the subjects to continue taking over-the-counter nutrient supplements, including vitamin D, which really make no sense to compare with the placebo. Then inadequate vitamin D doses were given, and the level achieved in the circulation was not measured systematically. And there is a possibility of reverse causation, and many of the studies are underpowered statistically. Here's one of them. Is one of the largest studies, the VITAL study, which is what you call vitamin D and omega-3 trial. They used a 2000 international units of vitamin D against a placebo. They concluded vitamin D supplementation did not reduce the incidence of cancer, cardiovascular diseases, or overall disease-specific mortality. However, when you look at the basics, most of the participants in this VITAL study had a vitamin D level above 30 nanograms per ml. So how on earth you expect any benefit by giving additional vitamin D? So from the design point onward, this study was flawed. This next one is a Vit.D study, vitamin D assessment study, compared the vitamin D3 100,000 units given on a monthly basis. So baseline participant of this study also had a near normal vitamin D level of 26.5 nanograms per ml. With the scatter, quite a few of these subjects had the vitamin D level going all the way up to 40 nanograms per ml plus. In addition, they had a higher calcium intake, and most of these meta-analyses have actually excluded participation of such studies. This study too failed to demonstrate the reduced incidence of fracture, falls, cardiovascular disease and cancer. Ironically, at the time this study was conducted or designed, there were plenty of evidence to suggest that intermittent administration of vitamin D, like monthly, 3-monthly or once a year, has no beneficial effects. Yet they conducted this study. The last one I'm going to discuss is the D vitamin D in type 2 diabetes, where they studies the progression of pre-diabetes to type 2 diabetes over 2.5 years. Unfortunately, this study too, the mean value exceeded 30 nanograms per ml at the time of recruiting subjects for this study. So, as with most other recent major clinical trials, this study also had a negative effects, muddling the field of vitamin D. So let's set the additional issues related to these large, expensive vitamin D studies. The principle is for nutrient studies, it's extremely difficult to conduct the proper randomized control studies, which are in fact unnecessary. Although they are considered as the gold standard, as we see, the nutrient interventions such as vitamin D randomized control trials are less feasible, and perhaps I could argue that they are unethical to carry out with a placebo arm. However, these can be overcome by well-designed, large, longer-term observational studies to assess the intended health outcomes. This allows testing for the hypotheses on varying exposure resulting in different health variable clinical outcomes. So here's a cartoon just to illustrate the pathogenesis and the outcomes of from COVID-19. So following the entrance, the COVID-19, it enters through the endothelial and epithelial cells of the pulmonary tract, through the ACE2 receptors into the lung, through the GI tract, and any other epithelial tissue cells. So this also aided by the abnormality or dysfunction of renin-angiotensin hormonal system, leading to a variety of disturbances of both the cardiovascular, gastrointestinal, and pulmonary epithelial and tissues, leading to lung damage, blood clots, pneumonia, and most of the cause of deaths are due to hypoxia. So let me discuss another important fundamental function. In this diagram is a hypothetical diagram showing the number of hospitalized COVID patients against the number of days and the outbreaks. So outbreaks are basically the natural infectious peaks occurring in the community, and the goal of public health intervention is to reduce these peaks to manageable diffuse incidence rate, so that hospitals will not be overloaded by large number of cases coming at the same time. Nevertheless, the number of cases in both cases are quite similar. So by this public health intervention, you are not necessarily reducing the number of cases, but the frequency of getting the infection. In contrast, in community spread, the spread is going up gradually and is present all all the time in different communities. So why there was so widespread community spread, especially with the Delta variant of SARS-CoV-2? There are a number of reasons. I think the number one is the wrong policies by the various government allowed that even the larger spread rather than controlling it. Poor compliance by the community with the public health guideline. Almost always due to the lack of trust of people of what the government and the spokesperson from various organizations is talking in the TV and in the other mass media. So lack of trust clearly has caused a lot of problems, and the people's behavior reference to public health guidelines. So losing efficacy of COVID-19 vaccines is another one happening right now in 2021, because especially with the new variant like Delta and Theta, which has immune evasion possibilities and also reduce the vaccine efficacy. So this emerging new resistant variant is going to be a major problem as in time to come. Finally, the ineffective disease managed by physicians. So let's look at this particular aspect of failure of management of COVID-19 in hospitals. So one of the reasons is the conflict of interest of committee members advising the respective governments. So because of their either due to lack of awareness of the biology of vitamin D and how it modulates the SARS-CoV-2 virus is an essential part of this failure. Secondly, they may have a conflict of interest not to approve the highly cost-effective drugs already approved and available in virtually all the countries, and thereby pushing the vaccine as a savior to overcome the viral epidemic. So I would like to switch to the concept of threshold nutrient with reference to vitamin D, which is very similar to iodine on behavior. These threshold nutrients provide the benefits up to a nutritionally sufficient threshold. Beyond that, no matter how much you take the nutrient, there will not be any beneficial effects. So supplementation with any of these threshold nutrients, the benefits occur only in the nutrient deficient subject. So that's one of the key principles that most of these large randomized controlled trials organizations fail to understand or implement. So recruiting subjects are already sufficient is a classic failure for disaster of this clinical study. So in this diagram, I'm going to show you discuss about the dose response curves of drugs commonly used and against the micronutrients. So the line in green is a typical drug behavior in the circulation and against these responses to the doses given. So most of the drugs behave in this manner with the higher the doses, which usually expand at least 2 order of magnitudes and provide the effects. In contrast, nutrients has a very narrow threshold of rapid responses. As you see here, the vitamin D from 10 nanograms per mil to 100 nanograms per mil has a very rapid responses, below which nothing and above which no response, no more responses to the particular nutrient. So this range of therapeutic level is very much narrow compared to the dose response curve of drugs. So this is a crucially important factor those who design studies must need to understand. So let's look at a little more detail on the same concept. Here we are looking at the benefits from the supplement, in this case vitamin D, against the serum 25-hydroxy vitamin D level. So increasing clinical benefits occur through the muscular skeletal system, particularly when the levels are between about 15 to 30 nanograms per ml. However, for extraskeletal benefits, you need a much higher level of vitamin D, as you see in this physiological range. In addition, there is a threshold effect, and beyond which, no matter how much you give the nutrient, there's no benefits. And in fact, at a very high level, like 150 to 200 nanograms per ml, one could see adverse effects like hypercalcemia. So the poorly designed randomized controlled trials and meta-analysis is really confusing the field of any nutrients, and actually these are doing disservice for the scientific community. So baseline 25 hydroxyvitamin D concentration were not measured in many of these, or measured haphazardly. Most participants in this trial had a normal serum concentration, therefore further increasing of the level of nutrient make no sense. Vit.D and vital trials did not show protective effect of cardiovascular disease and cancer because most of them had already the sufficient vitamin D level. D study failed to demonstrate the clinical outcome because they were given intermittent doses of vitamin D. So how can we test hypotheses? By properly designing and conducting nutrient clinical studies. Firstly, it's essential to measure the baseline status at the time of inclusion of subject into a clinical study. Secondly, the intervention, in this case the change of the intake of the nutrient by supplements, must be meaningful. In other words, the doses should be right, not like 400 to 1000 international units of vitamin D, which we consider as almost as a placebo. And thirdly, they must confirm the change of nutrient status, the dose responses, by measurement of serum total 25 hydroxyvitamin D. That's necessary to test these hypotheses. And in addition, of course, it's almost better to optimize the other core nutrients necessary for the optimal function, as in the micronutrient in the case of immune system. In the case of pregnancy, vitamin D deficiency is very common and actually get worse during the pregnancy. Up to about 60 to 80% of the women going through pregnancy is thought to be having vitamin D deficiency. So some of the analysis has showed that vitamin D supplementation reduced preeclampsia, low birth weights, and preterm birth, as well as infant improve parameters related to infancy and the childhood. And also, many studies now have confirmed the need of vitamin D 6,000 international units per day before and during the pregnancy, so as well as during the post-lactational period. So many of these recent studies, well-controlled RCTs, has shown multiple benefits of the maternal, fetal, as well as infant by supplementation during and pre-pregnancy period. So in summary, the above 20 nanograms per ml is adequate in the risk of reduction of the musculoskeletal disorders like rickets in children and osteomalacia in adults. Above 40 nanograms per ml is reduced to reduce the risk of diabetes, CNS issues, as well as adverse effects of during pregnancy and improved birth outcomes. However, above 40 nanograms per ml is necessary to reduce infection, especially COVID-19, autoimmunity, cancer, and to improve all-cause mortality. So evidence from observational studies and clinical trials indicated that vitamin D deficiency is associated with multiple adverse health outcomes. Other disorders such as metabolic syndrome, asthma, COPD also get worse when the person continues to have vitamin D deficiency. It also affects a variety of central nervous system disorders, including Alzheimer's, memory disorders, Parkinson's disease, multiple sclerosis, and other neurological disorders. So correction of the vitamin D deficiency not only prevent these disorders, they are getting worsened, the rapidity of establishing diseases, but also can reduce the severity. So while meta-analysis and systematic review can be useful, it also can have a confounded by the conflict of interest and the type of studies include or exclude for the analysis. So there's a study bias related to investigators mostly. Many have excluded randomized controlled trial with combined vitamin D and calcium supplementation, for example. But people don't understand that the calcium supplementation alone may not be work in a person given with hypovitaminosis D. So these drugs, this nutrient works in combination. Similarly, the authors could include the futile studies such as a very short duration or small sample size and providing meaningless clinical outcomes. Studies with a fail, such as high bolus dose of vitamin D given every 6 months or every 3 months, should not be conducted to start with and should not be included in the analysis of meta-analysis and systematic reviews. Thirdly, the oral vitamin D, such as 5,000 a day, even that takes several months to raise the serum 25-hydroxy concentration above 50 nanograms per ml, which is necessary for immune system. Even if you take 50,000 interaction units per week, it takes several weeks before one can build up the blood level. This can be reduced to up to about 2 to 3 days by giving the larger upfront loading dose such as 200,000 interaction units early as possible. The second way to overcome this the difficulty of the delay in getting the serum vitamin D level raised to stimulate the immune system is to use Calcifediol, partially activated vitamin D, which can raise the serum 25-hydroxy concentration within 4 hours, and thereby boosting the immune system starting within half a day of administration. Just one slide related to toxicity of vitamin D, published by Grassroots Health. It basically shows that the serum 25-hydroxy, in this case nanomoles per liter, to develop toxicity, one need to have thousands of nanomoles per liter, and that is about 250 to 500 nanograms per milliliter. So below that there is no toxicity. So these drugs are these nutrients are very safe within the recommended range. In fact, there is no toxicity below 200 nanograms per milliliter. So with reference to SARS-CoV-2 infections, what we need is to have develop immune protection against them early as possible. However, this is kind of a cost-effective treatment, but it's prevented by sun avoidant behavior causes hypovitaminosis D in many vulnerable people. So the way is to actually enhance the absorption or the increase in the rate of circulating 25-hydroxy vitamin D by providing Calcifediol to reach the target level within 4 hours of administration. Another key area that confusing and muddling the field of vitamin D, so as other nutrient, is a conflict of interest at every level of the concept of this agent. And here I'm just going to mention about the so-called committees and appointed expert panel such as NICE, SCAN in UK, and even the WHO committees, Many of the committee members either have no clue of the biology of vitamin D and how it modulates the viral diseases, or they have a conflict of interest to avoid prescribing cost-effective or avoid approving of cost-effective medication like vitamin D, ivermectin, melatonin, etc. to control COVID-19. So this failure to understand or conflict of interest lead to prevention of using already approved and available drugs, simple drugs as I mentioned, vitamin D, Calcifediol, and ivermectin globally to prevent complication and death from this important disorder. Consequently, they only promote vaccine and dependent on the vaccine, which is bound to fail altogether. So, what are the other conflict of interest? One of them is seriously conflicted with the monetary and other perks they are getting from various sources. So those conflict of interest bias them, and so as their decision-making organization, as happened with the WHO and some of the governments. Pushing vaccine as the only way to overcome COVID-19 is another failure of lack of understanding of the biology as currently happening in the United States, United Kingdom, and perhaps in some other countries like Australia and lately Sri Lanka. Because this really has to go with the multiple other variables, including the adhering to public health guidelines and nothing more important than stimulating and increasing the robust immune system of the population. So consequently, they dismissed the highly cost-effective established agent for COVID-19. So this is the diagram I put together to understand the overall effect of aging, because we know that the older the person, higher the risk of developing complication and death, and partly because they have a lower H2 concentration, they have a lower vitamin D, therefore their endocrine system and the immunological disorders much higher compared to the younger, therefore they get higher rate of infection and develop complication and death. Similarly, this can be avoided. They also have a chronic diseases coexisting, and then vitamin deficiency together with the public health and other issues including epigenetics worsen the situation and enhancing their premature deaths. The one slide from reverse causality and the vitamin D doses. It's a possibility, or at least in theory, to have a reverse causality, that inflammation could actually rapidly reduce the level of what you measure in the blood at 25-hydroxy vitamin D. However, the recent several studies have shown that the effect of reverse causality, although there, it's very, very small component in reducing the serum 25-hydroxy vitamin D. So for COVID-19, we can actually forget about the reverse causality effect. Secondly, the government recommended doses of 400 to 800 international unit of vitamin D makes no sense. As I said, it's no more better than the placebo in raising serum 25-hydroxy vitamin D concentration to therapeutic level. Because doses such as 400 has absolutely no effect in increasing blood levels of 25-hydroxy vitamin D. Yet that's what's happening throughout the world. There are no risk of hypocalcemia even with the longer term use of doses up to about 20,000 a day. However, the recommended upper limit is not 10,000 international unit, but people with obesity taking medication that enhance catabolism of vitamin D might need even a higher dose than this to maintain this blood levels of 25-hydroxy vitamin D. So in physiological terms, the blood pressure and extravascular fluid volumes are all controlled through the renin-angiotensin hormonal system. So when there is adequate calcitriol production, the hormonal and non-hormonal forms, it reduces the renin production, which is the rate limiting step of this entire axis. So it produces the less angiotensin 1, less angiotensin 2, because it reduces ACE production and increased ACE2 production. Therefore, angiotensin level is controlled at the physiological level. In fact, the breakdown product of angiotensin 2 is a potent vasodilator. So it maintains the blood pressure, normotensive and physiological lung function. So the issue is when you don't have the vitamin D deficiency adequacy. In other words, vitamin D deficiency, it reverses the entire axis. It increases the renin production. That means it increases angiotensin 1, angiotensin 2 levels in the blood. It increases the comorbidity as it affects almost all the systems, increased blood pressure, pulmonary hypertension, and chronic pulmonary disease and tissue destruction, and causes premature death. So what about the coronaviruses like COVID-19? It by itself actually causes the reduction of ACE2 enzyme. Therefore, the angiotensin 2 will build up to a significantly higher level, which causes activate the A2-1 receptors, increasing pulmonary hypertension, increasing blood pressure, pulmonary edema, acute respiratory distress syndrome, and premature deaths. However, even in the presence of coronaviruses like COVID-19, if you have adequate calcitriol level intracellularly in particular, it can reverse the situation back to the physiologic renin-angiotensin hormonal axis, thereby reducing the production of circulating angiotensin 2 and protect from the cytokine storm, pulmonary edema, hypertension, and indeed prevent acute respiratory distress syndrome. This is exactly what we need in people developing coronavirus syndromes. So if you look at the summarized fashion, it's the vitamin D reduces the entry of the virus and multiplication together with other micronutrients, can also reduce the lung damage, whether it's a chemically induced lipopolysaccharide or directly from viral damage. And renin-angiotensin system also activity reduced by vitamin D, so as the angiotensin receptor blocker drugs many hypertensive patients are already taking, and also to protect the renal functions. So those people who are already taking ARBs and ACE inhibitors should not discontinue this medication, as they may have a protective effect. The role of monoclonal antibodies and expensive antiviral medication is very limited to very small number of patients, so as the use of the dexamethasone and other potent corticosteroids only in a very selected patients go to the within the intensive care unit environment. So in addition, the use of ivermectin, vitamin D, and melatonin has been shown to be protective by several groups, particularly the FLCCC group in the United States. So sustained higher 24-hydroxy concentration are associated with a lower risk of diseases, complication, progress of the disease, as well as a reduced mortality. Vitamin D supplementation reduces risk of premature deaths irrespective of the age of the person. Randomized controlled trial evidence supports that diseases such as cancer, acute respiratory tract infection, and including COVID-19, as I discussed in detail in the keynote speech on this international conference. So, as a preventative approach, vitamin D doses can be taken as a 5,000 international units, but it takes several months to achieve the therapeutic level. Even the weekly doses, as I suggest, to take about a few weeks to reach a level above 50 nanograms per milliliter. So person with obesity, chronic comorbid conditions, daily doses are going to be much higher, in the range of 10 to 15,000, because they are either catabolized 25 hydroxyvitamin D quicker, or because of sequestration in the fat and musculoskeletal tissues. Ivermectin, the preventative dose is between 0.2 and 0.3 milligrams per kilogram body weight. That comes to about 12 to 24 milligrams every other week, or 6 to 12 milligrams once a week. In any case, if anyone interested in taking this medication, it's available in virtually all the countries. You should work with your own general practitioner or the primary care physician in make that decision and manage under their condition, their supervision. For treatment point of view, the best option is to use Calcifediol, partially activated vitamin D, it's 25 hydroxyvitamin D. The dose range between 0.5 and 1 milligram, which acts within 24 hours and increased immunity within 12 to 24 hours. So dose calculation, one should use the dose 0.014 milligrams per kilogram body weight, and in addition to administer the loading dose of 200,000 international units earliest possible, immediately after becoming PCR positive, or at least at the time of the admission to a hospital. These will significantly reduce the need of hospitalization, admitting to intensive care units, and indeed deaths, approximately by 75%. The treatment doses of ivermectin, there are several protocols available, and the most commonly used protocol is using the 0.4 milligrams per kilogram body weight between 12 to 36 milligrams based on the body weight. So this can be used once daily for 5 days from the time you acquire the disease, or 25 milligrams stat dose followed by 12 milligrams on day 2, 4 and 6. Again, this can be adjusted to the body weight. Higher the body weight, higher the dose needed, in conjunction with your own doctor. So in summary, having serum 25 hydroxy concentration below 30 nanograms per milliliter in the longer term is associated with both acute and chronic multiple disorders, and clearly has shown that it increases the deaths earlier than otherwise will happen. With reference to reduced disease risk, what matters is not the dose one taking. As I said, in the obese patient taking 5,000 international units makes no sense, because it may not even touch the serum 25 hydroxy level. So what matters is whatever the serum level of 25 hydroxy D concentration achieved and maintained on a longer term basis. So those with the serum 25 hydroxy concentration above 50 nanograms per ml will have a major advantage in overcoming COVID-19. This can be achieved with higher doses of vitamin D, such as 5,000 and upwards on a daily basis, or 50,000 either once a week or once in 10 days, will definitely maintain the serum level above 50 nanograms per ml on about over 96% of the people. The remaining 4% are with the other GI and other disorders going to need much higher doses. So by administering Calcifediol 0.5 to 1 milligram will certainly expedite the raising serum levels and the boosting of the immune system. So in summary, vitamin D, ivermectin, melatonin are highly cost-effective agents in prevention of complication of death from SARS-CoV-2. This can be used alone or mostly more effectively in the combination. The use of the combination with Calcifediol 1 milligram and 200,000 vitamin D should be the part of the standard care of managing COVID-19 in 2021. Yet, despite all this data available, very few places or hospitals utilizing this highly effective management of COVID. So again, the calcified dose can be from 0.1 to 0.1 milligrams, whereas 200,000 unit vitamin D in fact comes to 5 milligrams, not a massive dose, in administering together with ivermectin or independently. Thank you for attending this program and hope to see you soon.